Interestingly, a patient with vestibular migraine can have almost any kind of vestibular symptom. They can have the typical spinning kind of vertigo that patients with an inner ear problem can have. They can also have a lightheadedness. They can have also some other symptoms which the inner ear cannot create. Typical among these is a sense of disorientation in space. This is something we call the Alice in Wonderland syndrome, where the patient feels as though they're really have shrunk and are sitting perhaps a few inches behind where they really are in space.
When we put out the call for topics last year in preparation of this year's Migraine World Summit, we were flooded with calls for a world-class expert to discuss all forms of balance-related migraine symptoms, which can be just as debilitating or even more so than the migraine condition itself. Introducing Dr. Michael Teixido. Dr. Teixido is an otolaryngologist with a special interest in medical conditions that affect hearing and balance. He participates in many national professional organizations and is a frequent speaker to both professional colleagues and the public. He teaches residents at Thomas Jefferson, University of Pennsylvania, and is the director of several medical programs, including the Balance and Mobility Center of Christiana Care. Dr. Teixido, welcome to the Migraine World Summit.
It's great to be here, Carl.
How can migraine cause balance issues?
That's a great question. Migraine is a process that involves all parts of the brain. And the networks of neural pathways that control our balance are a part of the brain which can be affected by migraine.
Can you describe the likely pathophysiology or the way that it interacts? Like what's happening in our ears and in our brain?
Well, balance can be considered the sixth sense. We possess a sense of orientation in space because of 10 tiny balance organs which are constantly working in the background. We have 5 in each tiny inner ear. 3 of them sense turning, and 4 of them sense back and forth, up and down, and side to side motions. These tiny organs are constantly working in pairs with one another, like the wheels of a car, which are in alignment, and so that when we turn our head and move our body position in space while looking at something, we do not lose our sense of position in space. And if the mechanism is distorted in any way, either in the inner ear, in the nerve going from the inner ear to the brain, or anywhere in the brain, then we can lose our sense of orientation or have a sense of spinning, of motion, of being displaced in space, many different sensations.
Why do some of these sensations or symptoms affect some people with migraine but not others?
Well, actually it's quite common. About 25% of migraineurs do experience dizziness at some time, making it perhaps the most common cause of dizziness. In the United States alone, about 2.7% of individuals probably experience vestibular migraine. The reason that some individuals are susceptible to migraine more than others may have to do with a different pathophysiologic mechanism that originates from their genetics. We know, though, that migraine is a genetic disease, but that the expression of the very same genetic imprint may be very different, even among the members of a single family, all of whom have migraine. In fact, I frequently meet patients who tell me that, yeah, we have migraine in my family, everyone else got it, but I didn't get it. In fact, they did get it. They got theirs as vestibular migraine. And in their case, the cardinal symptom of migraine, headache, isn't even present.
So sometimes you can have migraine and not even have headache.
That's exactly right. There are very many additional manifestations of headache other than the head pain.
What still don't we know about the relationship between vestibular migraine and the brain?
Well, we don't know more than we know. We are learning that processes that can affect balance can occur at the cortex, like aura symptoms in some patients. And in those cases, the dizziness actually precedes the migraine headache attack, just as a classic visual aura might appear before a classic migraine headache in some individuals with headache. In other individuals, the change may occur because of changes in activity in the vestibular nuclei. This is the processing center for the information from the inner ears. Others may have changes that affect pathways that interconnect the vestibular nuclei and other centers in the brain. And still others may have symptoms because the very same changes in blood vessels that are caused by CGRP and other inflammatory peptides that are receiving so much attention now in migraine are also in the inner ear itself. So we think that some patients with vestibular migraine really do have symptoms coming from the vestibule, which is the inner ear.
How is vestibular migraine diagnosed?
Well, we don't have any specific test for vestibular migraine at this time, but we recognize it with a high index of clinical suspicion, and by recognizing what we would see as a classic migraine pattern of disease. Well, what does that mean? The typical patient would come to me with a new onset of symptoms of dizziness, and during the same period of months, they may have an increase in headache activity. Now, their headaches may not be classic migraine headaches, and they may not even occur at the very same time as their vestibular episodes, but they did come on at the same time. And some of their headaches and some of their vestibular events and symptoms may also come on in response to classic migraine symptoms, triggers, like weather change or stress or fatigue.
So I think you hinted at this earlier, but what are some of the typical symptoms that patients have with vestibular migraine?
Interestingly, a patient with vestibular migraine can have almost any kind of vestibular symptom. They can have the typical spinning kind of vertigo that patients with an inner ear problem can have. They can also have a lightheadedness. They can have also some other symptoms which the inner ear cannot create. Typical among these is a sense of disorientation in space. This is something we call the Alice in Wonderland syndrome, where the patient feels as though they're really have shrunk and are sitting perhaps a few inches behind where they really are in space. This is the sort of disorientation in space I was alluding to earlier. Other patients feel a rocking sensation. Now, if you injure the paired one of the two inner ears, then you create a deviation that causes you to keep turning in the same direction. Well, there is almost no inner ear problem that can cause you to move back and then back to the other direction and then back and forth continuously. This rocking sensation is something that is a red flag for the clinician. Almost all of these patients have vestibular migraine.
Is it the same thing as migraine-associated vertigo? How are they the same or different?
Yeah, migraine-associated vertigo was the term used by the neurologists in Germany who first described this distinct association between migraine and vertigo symptoms. But the criteria they had were rather loose. They were so loose, in fact, that all you needed was just to have a response to a migraine-active medication to prove the diagnosis. That wasn't strict enough for study. So after many years of discussion, the International Headache Society coined a new term, vestibular migraine, that has more strict criteria to be used prospectively to study the problem of vestibular migraine. So from a terminological standpoint, they're the same, they are distinct. And for patients, it doesn't make any difference at all, because all of the patients should receive the same treatment. The only difference is really in this particular criteria that we need to do epidemiologic studies and drug efficacy studies. So without those strict criteria, we can't do good science. The problem is that some people use those criteria as a way of learning about the disease, and then they use them unintentionally sometimes as exclusion criteria. Say the patient is here and he doesn't quite check all of the boxes, so they say, well, then you don't have vestibular migraine. If you're too officious with those criteria, there are very many patients who could be helped who aren't going to be.
Beyond a genetic disposition to having vestibular migraine, are there any causes?
Well, you can't catch vestibular migraine.
It's not contagious.
No, fortunately, but you do find, and almost everyone who has it has a memory, as do most migraine sufferers, of being sick in the back seat of the car in childhood. This is because almost all migraine patients have increased sensitivity to all sensory inputs, not just the balance. But patients with vestibular migraine have an extraordinary sensitivity, especially to tilting. If we measure, for example, how sensitive one of our balance organs is to sensing the degree of tilt of our body in a totally dark environment, migraine patients are more sensitive on average than normal individuals. They're at the sensitive end of normal. Patients with vestibular migraine are super sensitive. They're in a world of their own. They can sense unbelievably small tilts, and we think that this has something to do with why they are so intolerant of sometimes even motion of their own head.
In the way that migraine has triggers that can cause attacks, is that the same for vestibular migraine patients?
Yes, so a patient with vestibular migraine may notice that they're having a lot more attacks on days when they're very fatigued, on days when the weather is changed, when they are stressed, or in response to specific migraine triggers such as foods. The pattern is very variable.
So the triggers for vestibular migraine could be the same as they are for migraine in general?
That's right. It's just a different, unique pattern of expression of disease. The only real implication is that it may be treated slightly different.
So we asked people in our community about this topic, and we had a very enthusiastic response from our community. A lot of people are very interested in this topic. One of those people is Karen, and she would like to know if vestibular migraine could be as simple as something like fluid in the ear.
Well, that's a complicated question. A lot of patients think about having fluid in the ear, which means fluid, I presume, behind the eardrum, like an ear infection. Fluid behind the eardrum is not the cause of vestibular migraine, and usually is not the cause of dizziness itself. That said, a lot of patients with vestibular migraine do have a sensation of pressure in the ear. And because of that complaint of pressure in the ear, we spend time making sure that there's no negative pressure, that there is no fluid accumulation in the mastoid or in areas around the ear that we cannot see simply by looking through the ear at the eardrum and middle ear. And we think those patients actually are sensing a pressure neurologically. The way we have a very mild headache that is not painful, but it just feels like a pressure, but it is displaced to the ear. Patients often with migraine often also have sinus pressure, which we now know most of those patients have migraine, but they're feeling it in the sinuses instead of in the head. Patients with vestibular migraine are often having pressure that they're feeling in the ear because that is their pattern of disease.
Those with vestibular migraine have said that these symptoms can very quickly become more debilitating than the headache itself. How common is that?
Well, it's quite common. We have a lot of patients who have been living with headaches. In fact, they have submitted to a lifetime of living with headache, and then it is their new onset of dizziness that has now brought them to the doctor. They didn't know that they had chronic migraine. They didn't know that their headaches were migraine headaches in the first place. This is because there's a general conception out there that there is a very classic, identifiable sort of migraine, and that is on one side and with pounding, and that has associated with an intolerance of light and sound, and when you have to lie down, sort of a sick headache, if you will. And we have to remind our patients that there are many forms of migraine that they have not heard of, in addition to that classic form. And they've learned to bear through with their headaches and get their life done. But the symptoms of dizziness are very worrisome to them and often debilitating. Because of their new dizziness symptoms, they can't tolerate motion. The more they move through the day, the more sick they feel. So all of a sudden, even though they were slowed down by headaches with their dizziness symptoms, they become unreliable for the first time, and often during some of the most productive years of their lives. They can't do the things that they need to do, that they want to do, or that they said that they would do.
It sounds like, and this is another example about why migraine is such an evil disease, is you can have the headache attacks and head pain and be focusing on addressing that, and then in the background you have this sort of dizziness or instability, and eventually that takes over as the primary symptom, and before you know it, it's happening all the time and becomes more debilitating than the headache.
That's right. Well, there's a general pattern in the course of the life of a migraineur, and young patients often will have very severe classic style headaches. And those headaches, thankfully, become less severe over time. They sort of burn out. It's almost as if those little unmyelinated nerve endings around the blood vessels wear themselves out because the chemical mediators that they secrete are so toxic. But later in life, the secondary symptoms of headache take center stage, and dizziness is such a common secondary symptom that it is often the second big presenting symptom. So a person who had migraine, but they thought their migraine went away decades ago, comes in with new dizziness, and they insist that they don't have any headaches. But on further inquiry, we find that, they do have headaches. It's just a mild pressure. It's always there. It never goes away. And it came on again at the same time that they started with this dizziness. So their headaches have diminished, but the vestibular symptoms are now very prominent.
Is vestibular migraine often misdiagnosed?
Oh, well, very often. It is very easy for vestibular migraine to be confused with other common vestibular disorders. So if you have a minute, let's take a look at just the broad range of just the few diagnoses that account for over 95% of patients with dizziness. The first one is benign paroxysmal positional vertigo. This is a type of dizziness that most of us have heard of by now, caused by loose crystals in the inner ear, and those crystals get into the balance canals where they don't belong, and when we lie down or tip our head up or roll over in bed, those crystals which are in the canals fall to a new position. When they do, that falling pushes gently or pulls on one of the balance triggers and causes us to turn as if we're doing a somersault. It is very startling. It's a strong response. But it doesn't last very long, only 30 or 40 seconds at the longest. The patients with vestibular migraine are very sensitive to head motion. They often will answer yes to the specific questions that are asked when we're asking whether or not when we're curious if the patients have loose crystals. Those questions are, do you get dizzy when you lie down in bed? And do you get dizzy when you roll over in bed? And the vestibular migraine patient will answer yes to those questions because lying down and rolling over are head motions, and they're sensitive to every head motion. So that's one reason that the two can be confused. The patient can be treated with some sorts of exercises as if they have these crystals, but they won't help. In fact, the exercises may be a little bit of a torture for the patient with vestibular migraine. Now, another interesting reason for confusion is that the symptoms in vestibular migraine sometimes can last just a few seconds, as well as they can last for hours, days, or even months continually. But in those patients who have these very brief episodes, that can make physicians think that, aha, this must be crystal dizziness, benign paroxysmal positional vertigo, known as BPPV, and lead them down the wrong track. Now, the third and most surprising reason for confusion is that about 22% of patients with vestibular migraine really do have loose crystals. I looked at 500 patients and in my dizziness clinic, and of those 500 new patients, 47% of them had vestibular migraine, but 22% of that group actually had BPPV at the same time as their initial diagnosis.
Just in case matters weren't complicated enough.
Well, it's interesting because why would a patient with vestibular migraine tend to have loose crystals in their inner ear? This is a problem that generally happens with older patients. When we get older, these crystals we have are always renewing themselves. They fall off and they get dissolved in the inner ear and they're replaced by new ones. You lose them and I lose them. But when we get older, we tend to lose more and faster than we can absorb, and we tend to get benign positional vertigo. But the patients with vestibular migraine can be younger. And we say, well, why does this young patient have loose crystals? And it may be that they also have vestibular migraine and that it's the vestibular migraine process that is in the inner ear that is injuring the otolith organ and causing the shedding of these crystals. So this is testimony to the fact that that migraine mechanisms have an ability to injure the inner ear.
What other common misdiagnoses might there be for someone who has vestibular migraine?
Well, the next most common is equally complicated. It's Menieres disease. We've all heard of Menieres disease. Menieres disease is a problem of an unknown cause in the inner ear, which is characterized by a fluid imbalance and accumulation of a particular inner ear fluid. Patients with Menieres disease will always be able to tell you which is the ear that has Menieres disease because they have a sense of fullness and pressure in the ear, a ringing in the ear, changes in the hearing levels, and episodes of vertigo. And you might say, well, doesn't that sound a little like vestibular migraine? You just said that patients with vestibular migraine have some fullness, and of course they do. So we think that there is a spectrum in which some patients we see have vestibular migraine, and other patients we see have Menieres disease, and others have a little of both, and some definitely have both. It may be that the inner ear of patients with in some patients with migraine gets injured by their migraine, and that injury turns into Menieres disease. The co-occurrence of Menieres disease with vestibular migraine is some proof of that, but in the general population, we have about 13% prevalence of migraine. But if we look at patients with Menieres disease, 56% of them have migraine. And if they have Menieres disease in both ears, 85% of them have migraine. So we think that this is not a coincidence.
Let's talk about some of the treatments available for vestibular migraine and potentially how effective they might be.
Well, in stark contrast to migraine headache, we don't have good treatments for vestibular migraine that are useful at the time of an attack. The best strategy for these patients is to take preventive medication and to prevent the episodes altogether. That is because most of these patients have very frequent episodes. So they're having symptoms more than half of the days of every month, most often every day. And by migraine criteria, that would be chronic. So most vestibular migraine patients have chronic migraine. And chronic migraine needs to be treated with preventive medication. So we use the same medications that we use to treat chronic migraine headache, and those are 4 classes of medication. But in vestibular migraine, we also add on a couple. So one of the most common groups are the sodium channel blockers. These are seizure medicines. And then we have calcium channel blockers. That's a blood pressure medication. Then we have beta blockers, another blood pressure medication. And then we have a group of serotonin drugs that seem to be quite good for patients who have vestibular migraine in particular. They're not as good for some patients with headache, but when headache and dizziness are together, they seem to be quite effective. Some patients also require, especially the patients with rocking, benefit from anti-anxiety medications, partly because they do get so anxious when they have those symptoms, and their anxiety creates a vicious cycle that propagates their symptoms, but also because those medications have a specific mechanism of action both in the central nervous system and in this very sensitive otolith organ that suppresses its signals.
So those are some of the medicinal treatments that might be used to prevent attacks. Are there any other modalities like devices or procedures that might be considered?
No, there are no devices or procedures, but just as important as taking medications are the reduction of triggers. It's easy to tell someone to reduce the stress in their lives, but it's quite difficult. It takes a really concerted effort on wellness and spiritual growth for an individual, especially one in crisis, to embrace that sort of an approach. And in any case, many of the circumstances which have put them into their crisis are beyond their control. They may be work-related or relationship-related, financial stress. And one thing that is, I think, very, very important is to reduce the migraine triggers which are in the diet. We stabilize. The purpose of taking medications is to stabilize the brain. We, in essence, have a personal threshold for migraine. And when we stabilize the brain with these medications, which partially block ion channels, the threshold elevates. In this way, there's more room for triggers to add up without putting us over our personal threshold. In terms of taking away triggers, the easiest group of triggers to reduce are the foods we put into our bodies. So I give patients a comprehensive list of foods that we know have been compiled from many different migraineurs. We know all of these foods aren't triggers for them. But if you're having migraine symptoms almost every day, how do you know what your triggers are? You can't tell. So I tell my patients that the very first thing we're looking for with this strategy of elevating the threshold and reducing triggers is to go from nearly constant symptoms to intermittent symptoms. That way they can look back after 10 days of doing well and having a crisis and ask themselves, what was different in the last 30 hours? And over a few episodes, what pattern starts to emerge, which will allow me to make more progress. I've allowed myself to become fatigued, and I'm going to avoid that in the future. I didn't exercise, and I'm going to be more consistent with my exercise, and that makes me more resilient.
Do you think these types of behavior and lifestyle interventions or changes in behavior are often underrated?
Yes, I think that they are often underused because they take a lot of time and energy on the part of the physician. You have to really spend a lot of time to enroll your patients into the project of treating their dizziness as migraine. As I mentioned, most of them have an idea already of what migraine is, and you're telling them that it's something else. They have to be won over with this new paradigm and to fully participate in their treatment. And so just that enrolling takes a lot of effort. And that's the reason I usually send them a link to my website, where I have prepared an article which is called More Than a Headache, Migraine, More Than a Headache. And this explains what migraine is in a more general terms beyond headache, and all of the very variable presentations of migraine that occur. And often they discover that they have other manifestations of migraine that didn't come up in our initial interview, but which are just as important to them. Bowel problems in particular. Many patients say, oh, I've had irritable bowel for a long time, but since now I'm on treatment, I've been perfect. And the reality is they had abdominal migraine all along.
Yeah, I think it makes intuitive sense that if you do things that are just good for the brain in general, regardless of whether you have migraine or vestibular migraine or anything else, but if you're getting quality sleep, if you're minimizing processed foods in your diet, if you're exercising and moving regularly, that's just good for you in general. That'll help your quality of life and your longevity, let alone the migraine condition. And that's just I guess a bonus to it as well.
Oh, I think that people are discovering that in every field of medicine independently, that when all else fails, take care of your body, be careful of what you eat, don't eat too much, mostly plants. There seems to be some magic in that that's very harmonious for our physiology. But culturally, we're locked into a particular pattern. And when we go out for something quick to eat, the offerings are dictated by our culture, and they're not really very good.
I have to admit that I've certainly found that to be the case with my own condition, and as well as that, the spontaneous sort of bouts of vertigo that I'll experience has gotten a lot better by doing a lot of these suggested therapies. Speaking of therapies, is physical therapy something that could be considered for someone who has chronic vestibular migraine?
Well, yes, with caution. I think that as an otologist, I know my physical therapists, and I know that they are aware that there are some patients with vestibular migraine who we discover have weaknesses in one inner ear, so that their balance system is out of alignment in a sense. Physical therapy can be very good for retraining that and reducing symptoms. Physical therapy can also be helpful in identifying and eliminating loose crystals when they're present. But very often, physical therapists who aren't used to receiving patients with an established diagnosis of vestibular migraine are overworking their patients. It doesn't help a migraineur or a patient who is suffering with vestibular migraine, who's very sensitive to head motion, to work them so hard that they are incapacitated after every physical therapy visit for the rest of the evening. In fact, it's a step backward. So sometimes the physical therapists, they look for things that are going to be treatable, and then they are very careful how much they can insist with an individual patient. And sometimes the dose of treatment is only minutes, even though they have set aside a half an hour for that patient. They don't want to be injuring and be an obstacle to recovery for that patient. The patients, though, also can still benefit from that interaction, because a patient who is really affected with chronic vestibular migraine needs support. He needs other people who can corroborate and know that and who has seen this problem and has seen patients get better. Many of my patients, when I first meet them, they're really in despair, and they're not really believing that they're going to get better. So meeting with people who can give them the acknowledgement they need can be very healing indeed.
Are there any contraindications that patients should be aware of?
Well, the main thing is just overdoing movement. It's not one of those conditions where you can just hold your mouth right and bear through the pain, like getting back your knee mobility after a knee operation. That kind of physical therapy is different than retraining the central nervous system especially one with vestibular migraine that already, in a sense, has ADD and is not very capable to the task.
What should someone who comes to you expect if they have chronic vestibular migraine?
Well, they should expect to become a partner in their treatment. You know, I sometimes tell people that I can be their coach, and that an Olympic athlete knows where they want to go. They want to go and win a gold medal. And the coach can see from the outside what they can't see. The coach can check in with them and tell them exactly what to be doing, but really can't do any of the work himself. So I provide the direction and the resources. We check in and we catalog symptoms using a simple notebook calendar. We don't want to get too detailed, but we do want to know whether or not symptoms are present on a day and how intense they were on a simple scale, just 1 to 5. And by looking at that book, we can tell month to month whether or not the treatments we're using are working or not, and whether we should be changing medication, whether we should be adjusting the dose of the medication we're already on, or whether we should be thinking about other potential treatments or causes or triggers in an individual patient.
So we had Sandra ask a question saying that she's tried topiramate, Botox injections, venlafaxine, the gamma core device, vestibular, physiotherapy, craniosacral, acupuncture. How would you approach someone like this who's tried and failed so many different treatments?
Well, usually I start with the basics. I go right back to having them look at their diet and really try to reduce all migraine triggers. And at the same time, I can just tell from your reading that list that there are several main categories of migraine preventive medication which she hasn't tried. Often I find that patients have already tried a medication, and on further discussion we find that they did try it, and it's not that it didn't work, they couldn't tolerate it, so they stopped taking it after a few days or a week or two. So we don't really know whether that class of medication which was not tolerated will really work for that patient. We know that specific drug didn't. So if we crossed topiramate off then and excluded it, then we need to think, well, maybe another sodium channel blocker would work and would be metabolically compatible with her system. So we have to go back and be in a simple way thorough, because the majority of patients will improve. There was a nice study which used only 3 treatments, and 75% of patients improved. Patients were given either nortriptyline or topiramate. If they didn't tolerate one, they used the other, or caffeine cessation alone. Just reducing caffeine, which is an extraordinarily strong migraine trigger, which is so prevalent in our culture, had a 16% response rate.
Wow. So for 75% of people, they're likely to respond to one or more of those treatments.
That's right.
How can people develop better coping skills to handle the isolation and anxiety that comes along with constant dizziness that sort of leads them to be housebound most of the time?
Yeah, that's a terrible problem. This is where you have someone who is functional and active, and they may be under an extraordinary amount of stress, which they wouldn't want to admit that they were under a lot of stress when they were juggling so many balls, but their body is telling them, their brain is telling them that they aren't able to do that. But now the immobility and the illness, which is often the first major illness that a young person is facing, has rocked their world in a sense so profoundly that there is real despair on top of it. And that grieving is a kind of physiologic and psychic stress that just fuels the whole problem and makes it worse. Some patients benefit from counseling, and I always recommend cognitive behavioral therapy because it specifically looks at the way that the patient is thinking about their symptoms, and often they are catastrophizing or magnifying the impact in a way that doesn't allow them to have any sort of real rational response, and they can't get their head around what is happening because they just immediately go to an emotional response, and this of course makes their problem worse.
Do you think there's a little bit of stigma about going to a cognitive behavioral therapist or talking about these types of things as an admission of failure or you know, guilt on their part?
You know, less and less. I'm happy to report that my patients seem to be more and more receptive to this. Almost sometimes they feel that, oh, good, now that you've suggested it, I'm going to go, because there may still be feelings of that sort of stigma with other members of the family, for example.
And cognitive behavioral therapy actually has some very good evidence, in fact, grade A evidence for the treatment of migraine.
Yes, it is, I think, it's a technique of therapy that was developed in Philadelphia, and there fortunately are practitioners who specialize in these methods of inquiry. There is a very good handbook that patients can read if they don't have access right away to a cognitive behavioral therapist. It's called the Feeling Good Handbook. And this book has been around almost unchanged for 25 years, and it has been studied. Just giving the book to a patient has been studied in comparison to giving them medication. Wow. In depression and anxiety, and found to be equally effective.
Well, we'll make sure to link to that book to give everyone the opportunity to see it. For vestibular migraine, what type of expert should we be working with? Because this kind of straddles a couple of disciplines.
It does. The group of individuals who are most attuned to vestibular migraine right now are those individuals who have training in ear medicine and ear neurology. So from the neurology side, we call that an otoneurologist. From the ear side, from the ear, nose, and throat side, individuals who specialize in otology but also treat neurological conditions of the ear and neurosurgical conditions are neuro-otologists. So otoneurologists and neuro-otologists are few and far between. But because these cases that are impossible to get good results with are tending to concentrate to them, and because information about vestibular migraine is being disseminated at all of our meetings, patients are going to get competent treatment with those individuals.
Great. Now, there's been a lot of discussion about the CGRP monoclonal antibodies. Do you think these might help patients with vestibular migraine?
I really don't know. I don't think we have any knowledge or way to predict if CGRP may be one of the key mechanisms for generation of vestibular symptoms. But we can say that if we can slow down the chronic migraine, and this is true in many patients, when we treat, if they have vestibular migraine and a migraine headache, when we treat them for chronic migraine and their headaches diminish, very often their vestibular symptoms diminish as well. Now, there are a few individuals who are very intractable, and they say, you know, my headaches are gone, but I'm still dizzy. What are you going to do about the dizziness now, doctor? And we believe that those individuals who continue to have vestibular migraine symptoms despite successful headache treatment may represent a different genotype, a very special class of vestibular migraineurs.
Are there any upcoming new treatments or final thoughts that you would like to leave with the audience?
I think that that the biggest thing that's going to happen with vestibular migraine is that more and more individuals are going to become aware first that the diagnosis exists. And more ENT doctors, where patients primarily go for treatment of dizziness, are becoming aware of the fact that vestibular migraine is far more common than Menieres disease. Now, if you look at our textbooks, it's all about Menieres disease and no mention of migraine whatsoever. In fact, migraine isn't even in the curriculum in otolaryngology. Well, we should, if we look at the epidemiology, be seeing between 10 and 20 vestibular migraine patients for every one Menieres disease patient. But historically, we've been seeing it the other way around. 10 or 20 Menieres patients and maybe 0 vestibular migraine, and recently 1, but that number is going to start growing, and especially as otolaryngologists become aware that patients with vestibular migraine are going to come to them for treatment, and they're going to be very gratified with those treatment successes when they start using migraine therapies. So it's only a small step for them to start using just a small handful of preventive therapies for migraine to treat these patients.
Where can people learn more about you and the work you're doing?
I have a patient information page on my website at ENT and Allergy of Delaware, and I have a patient information page at the Delaware Biotechnology Institute at the University of Delaware. Also, I have a lot of teaching videos about inner ear and temporal bone anatomy and dizziness on my YouTube channel, Dr. MTCI. That's DRMTCI. We also have a website, the Association of Migraine Disorders, which a colleague of mine co-founded in about 6 years ago, Rick Godley, and this website is dedicated specifically to patients who have other migraine syndromes other than migraine headache. And it's a bridge organization that is connecting otolaryngology and neurology so that we can cross-fertilize. We actually never benefit from this absolute compartmentalization.
Dr. Teixido, on behalf of the vestibular migraine community, thank you very much for your expertise and your time today at the Migraine World Summit.
It's my pleasure, Carl. Thank you.